Okay, good. All right, all right, all right, all right. Good, 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 good. I'm seeing nice. People say Mary, Mary. Okay, sure. Great, great. Good time with the family. Beautiful, Dr. Oliveira. Okay. So look, let's get right into the game. So the rationale of this objective is that hypertension in children, hypertension, although is uncommon in children, and we all know that hypertension is uncommon in children, is usually due to an identifiable secondary cause. That is very critical. This is what the MCC objective is saying. Now, another thing they also say is that essential hypertension, which we learn that people usually get as they grow, is more common in adolescents. So if you have a child who is, say, 6 years, it is more likely that that child's hypertension is as a result of a secondary cause. But if I have an adolescent, say 15, 16, it is likely that that person may have essential hypertension. And we're going to take our time to even, go through so many things, So one quick trick for this rationale is this, and I want you to write it down. In a child with hypertension, you need to think about secondary causes of hypertension first before thinking about essential hypertension. The reason is very simple because the rationale said that hypertension, even though it is uncommon in children, is usually due to an identifiable secondary cause. So if I were you, I would start thinking, because the last time in our lecture, we looked at secondary causes of hypertension. Now, when we came to children, the objective is telling us that secondary cause of hypertension is more common in children, and in adolescents, essential hypertension is more common. So if I am in an exam situation and I am giving a child with hypertension, the first thing which should come into my mind is that this child's hypertension may be due to a secondary cause. Doctors, have I made my first point clear? If I've made my first point clear, type yes, 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 because today we are building on something very important. If I've made my first point clear, why don't you just type yes, yes, yes? Just type yes so that I know. Because now it is up to you to start finding, okay, what are the causes of secondary hypertension? What am I going to do now that Dr. Bruni is, talking about all these things? Secondary hypertension, secondary hypertension, secondary hypertension. Now, you also realize that in the objective, they also say that they group it. So this is also something I want you to do. When you are studying, I want you to group them. If I give you a case which says a newborn child and we check the blood pressure and it is high, you should be able to list the common causes of hypertension in those newborn children. If I give you a child who is, say, 6 years and I say that this child has blood pressure which is high, and you calculate the blood pressure, you realize that this blood pressure is obviously high, you must know the differentials. And you should also know the differentials of a child whose blood pressure who is more than 10 and whose blood pressure is high. Now, let's go through it. Neonates and young infants. What are the common causes of hypertension in neonates and young infants according to the MCC objective? Number one, renal artery thrombosis. And the renal artery thrombosis in these neonates and young infants is usually as a result of umbilical artery catheterization. So please, if you get someone, a newborn baby, they did umbilical artery catheterization for whatever reason, maybe the child had neonatal jaundice and they had to catheterize the umbilical cord and do exchange blood transfusion. And then later on, you realize that the child's blood pressure met really high. What you want to do is to note that then the likely diagnosis for this child is renal thrombosis. Let me continue. Number two, coarctation of the aorta. And we're going to take our time to look at all these differentials one by one. So please start thinking through them. Number three, Wilms tumor. And that was added by me. And I'll give that as an assignment as well at the end of the day. Neuroblastoma, congenital renal disease, and renal artery stenosis. We're going to take our time to look at how all these ones present in this lecture. As I said, today, really brace for impact. Number two, if you have a child who is between the ages of 1 to 10 years, what are the common causes of hypertension in these children? Secondary causes, renal disease. The child may have renal disease, And number two, that child may also have coarctation of the aorta. These are the two top diagnoses to consider in any child between 1 year and 10 years. And then if you come to a child who is more than 10 years, essential hypertension, because don't forget, we said that in children who are adolescents, essential hypertension is more common than secondary hypertension, renal disease, and as well conditions like coarctation of the aorta and renal disease itself. So let's get into it. So for me, from all I'm gathering, if I was to list the key topics I will learn for this objective, I will make sure that I cover renal artery thrombosis. I will make sure that I cover coarctation of the aorta. You see, I've underlined it because the objective is talking about it. It talks about it for children between 1 to 10 years. It talks about it for children above 10, for children below who are newborn. Then congenital renal disease, then renal artery stenosis. Then one other condition I will also want to focus on will be essential hypertension in children, and then renal disease in children. So now that we've done the introduction, Doctor, I don't want to move fast. If I'm moving fast, let me know, okay? Are we okay with the pace I'm moving so far, please? Are we okay with the pace I'm moving? Are we okay with the pace I am moving?
Yeah, Doctor, it's fine.
Okay, good. All right. So now let's move on to the next stage. So the key objective is this. According to MCC objective, and that is why I put the objective there. Given a child with hypertension, the candidate will diagnose the cause. Number two, the severity. Number three, the associated complications, and will initiate an appropriate management plan. Particular attention should be paid to distinguishing primary from secondary hypertension. If you remember very well, one day I showed you a particular, how will I put it, diagram from the medical council, and I'm going to show it to you again. The reason why they are saying this is that is exactly how they are going to examine you. And I'm showing you to you again here, okay? Please look at this diagram very well. Very important. Remember that the case was saying you must know the cause. So when it comes to dimensions of care and physician activities, they expect that how you assess a patient with hypertension should be high. How you also manage it. And then emergency room management and disease management. So a child with hypertension, the doctor must know that there'll be a lot of questions on assessment and diagnosis, how you're going to assess it, how you're going to assess it, secondary causes, what are the characteristics, okay? That will carry more marks, or that is likely to appear more in the exam. And then how you're going to manage it will follow. And then you realize that the rest is 10 plus 5, 10 plus 5. Then when you also come to the acute and chronic, you realize that how you're going to manage a child who comes in with maybe hypertensive urgency, and then how you're going to give ongoing treatment for hypertension is also very critical. So that is why I'm really taking my time to focus on the objective, because the objective is talking about these things. Diagnose the cause, the severity, associated complications, and in an appropriate management. Please mute yourselves. Okay, so an appropriate management plan, and particular attention should be paid to distinguishing primary from secondary hypertension. Okay, good. So now the first enabling objective, I labeled this enabling objective 1A. If you have a child with hypertension, the candidate will list and interpret critical clinical findings, including accurate measurement of hypertension and classification using blood pressure tables for children. These two things, please write it in your book as we are studying right now, that I'm going to learn the accurate measurement of blood pressure in children as part of my exam preparation. And then I'm also going to learn classification using blood pressure measurements. Now, the first thing I want to say when it comes to this is that when it comes to blood pressure readings in children, one thing I don't want you to forget is the number 13. Please write the number 13 in your book right now. The number 13. The number 13. Write it in your book before we continue, because for me, it is very critical. Write the number 13 in your book right now. Why do I say that? You realize that the number 13 is very critical, and it is simple. The reason why I'm saying number 13 is critical is this. If the child is less than 13 years old, hypertension is defined based on blood pressure percentiles for sex, for age, and for height. If the child is less than 13. If the child, however, is 13 or more, then their blood pressure readings are aligned with that of adults. And last week, that's what we did. We learned how to classify adult hypertension. So please, what is the lucky number we are going to use? What's the lucky number? What's the lucky number? Please, I want somebody to tell me. What's the lucky number we are going to use when it comes to pediatric hypertension?
13 years.
If the child is more than 13 years or above, use the same readings for adults. But if the child is less than 13, then use percentiles for sex, for age, and for height. And what do I mean by this? If the child is less than 13, you say that the child's blood pressure is normal. If the systolic and the diastolic blood pressure is less than the 90th percentile for the child's age, for the child's weight, and for the child's height. Let me say it again. If the child is less than 13, remember that we use the percentiles. If the child is more than or equal to 13, remember that we use adult values. Now, if the child is less than 13, how do I tell that this child has normal blood pressure? If the child's blood pressure is less than the 90th percentile. How will I say that this child has elevated blood pressure? You know, there's a difference between elevated blood pressure, hypertension stage 1 and hypertension stage 2, so far as children are concerned. So for me to say that this child has elevated blood pressure, that means that the percentile of the blood pressure is more than the 90th percentile, but is less than the 95th percentile. Doctors, can I move on? Dr. Froza, you've raised your hand. Please ask your question. Ask your question.
Doctor, what is 90th percentile mean? I'm into how do I measure 90th percentile?
So it's like the way they draw growth curves in children. Maybe let me take my time. Let me unshare the screen and then show you what we mean by that. Let's just go to Google, because we can blood pressure percentiles for pediatrics. Okay, so how do we do that? I'm just going to show you. So there's a chart. Okay, Dr. Froza, there's a chart. I get in the whole point. So there's a chart. So basically, when we say that the person's blood pressure is normal, if the systolic and the diastolic are less than 90th percentile, what it means is very simple. That means if you pick a child who is 1 year of age, okay, if the systolic blood pressure is 88 or below, that is fine. If the diastolic blood pressure is 39 millimeters of mercury or below, that is good. Dr. Frost, are you following me? So there's a chart that they follow. So you measure the blood pressure and then you go and check the chart and see how is this child's blood pressure doing. That's all. So and this is the chart. But you don't need to know this chart. It's not necessary. So when I say for percentile, that's what I mean. Are you now getting me?
Yes, doctor. Thank you.
Beautiful. Okay, good. So the same thing. You said that the patient's blood pressure is elevated, not hypertension stage 1, elevated if it is between the 90th percentile and the 95th percentile. Or 120 millimeters of if 120 millimeters of mercury is less than the 95th percentile, whichever one is lower. Then stage 1 hypertension, because the MCC wants you to know it, is if the systolic and the diastolic blood pressure is more than the 95th percentile to less than the 95th percentile plus 12 millimeters of mercury. I don't want you to memorize these. It's not very necessary. All I want you to remember is that the lucky number we use for hypertension in children is 13. And for those who are less than 13, we use percentiles to do their calculation. Those who are more than 13, we use adult values. That's all I want you to remember. Doctors, please, are we all on the same page? I just wanted to take you through some of these things so that you know that, yes, there's something like that. But I don't want you to memorize any of these. There's a simple formula we use, and that is what I've shown you. So in your exam situation, Dr. Froza, are you there? I want to quiz you a little bit, if you don't mind. Can you?
Yes.
Oh, okay, good. So assuming I say that you have a 2-year-old child, you measure the blood pressure, and the blood pressure, the systolic blood pressure is 115 millimeters of mercury. Is this child hypertensive or not for the systolic blood pressure alone, based on this formula? 2-year-old child, systolic blood pressure is 115.
Yes.
Why do you say that? Because
this is 90 plus 2 times 2 is 4, so it should be 94.
Beautiful. So the child's age is 2, times 2 is 4, plus 90 is 94. So that blood pressure should not be more than 94. But I said the blood pressure is 115. So that means that this child is hypertensive based on this simple formula. But if you want to get it accurately, you have to use the percentile charts. That's all I'm trying to say. Please, are we all on the same page? So please, write this formula down. Write this formula down. How to estimate the blood pressure of a child. If you forget that it is based on percentiles and everything, remember that the systolic blood pressure is the age of the child times 2. So if the child is 6 years old, then that is 6 times 2, that is 12, plus 90. That then becomes what? 102. So even for a 6-year-old child, a systolic blood pressure of 115 is still high. What about if the child is 14? In a child with 14, this formula will not apply. Because if the child is 13 and above, we use the adult values. Please do remember that. Those who are now joining, if the child is 13 and above, we use adult values. If the child is less than 13, then we use the percentiles, or we can use this formula to help us to estimate. As I said today, I'm having time for you. I really want us to grasp this concept very well. Can I move on?
Dr. Bruni, please, I have a question before you move on.
Please ask the question.
The systolic blood pressure, the formula you say is 90 plus H into multiplied by 2.
Yes.
Well, the one for 70 that we use 70 plus age in years times 2. Which age group is there? Which age group is that one used for one day?
I'll have to check. Just send me a message. I'll check it after the class for you, please. Okay, good. Okay, so I have a quick question here because we're still on blood pressure measurement. You are evaluating a 14-year-old male. I need somebody to volunteer and read this case for us, please. I need a volunteer.
I can read.
Please read.
Okay. You are evaluating a 14-year-old male in the clinic for an adolescent visit. Which of the following is likely true? A, the systolic pressure measured in the lower extremity generally is approximately 20 millimeters of mercury higher than measured in the upper extremity. B, the systolic pressure measured in the lower extremity generally is approximately 20 millimeters of mercury lower than that measured in the upper extremity. C, the systolic pressure measured in the lower extremity generally is no different. It's not different than the pressure in the lower limbs.
Please, what is your answer? Just type in your answer. A, B, or C. A, B, or C. A, B, or C. You are evaluating a 14-year-old male in the clinic for an adolescent visit. Which of the following is likely true? A, the systolic pressure measured in the lower extremity generally is approximately 20 millimeters of mercury higher than that measured in the upper extremity. Number 2, B, the systolic pressure measured in the lower extremity generally is approximately 20 millimeters of mercury lower than that measured in the upper extremity. And number 3, the systolic pressure measured in the lower extremity generally is no different Which people are going for no different? Which people are going for higher? Which people are going for lower? The answer is A. The answer is A. The answer is A, doctors. The answer is A. The reason why the answer is A is because the systolic pressure measured in, don't forget that the lower extremity, gravity is pulling on it, and so it is causing more pressure, right? And it is also dependent. The systolic pressure measured in lower extremity is approximately higher than that measured in the upper extremity. Please always remember that. Always remember that. And remember that especially when we get to what we call coarctation of the aorta. I want you to put it on the right side of your brain. That the systolic blood pressure in the lower extremity is usually higher than that of the upper extremity. Now, these are some facts I need you to know about blood pressure readings in neonates. Neonates. I'm talking about neonates. Newborn babies. Neonates. Newborn babies. Okay, good. So calf bladder should measure 2/3 the length of the extremity and 0.4 to 0.55 of the arm circumference. This is just quick facts I just need you to know. You don't really need it for your exam like that. Number 2, if you have to make a choice between a calf that is small or one that is large in a neonate, choose the large one. If you have 2 calves and one is way small and one is larger for the measurement, but you need to still get a blood pressure measurement, choose the large one. The reason is because the large one will give you less errors. Number 3, in a neonate, always do your best to measure the blood pressure in the arm in a neonate. And then number 4, if the blood pressure is to be measured in the leg, choose a calf size that is 2/3 the length of the leg. Please, iPhone, you've raised your hand. What is your question?
So what is the difference in the coarctation of aorta then?
We've not gotten there yet. I'm just saying, keep it in your mind. We will get there. I'm going to explain everything to you. Yeah. There's something unique about coarctation of the aorta that you need for your board exam. I'll tell you when we get there. I just need you to keep it in your mind that I'll talk about it. Dr. Froza, please, your question.
Doctor, I didn't understand the first point in here, but where it says 0.44 to 0.455. Is it percent or is it? I don't understand.
So 0.44 is like 44% to 55%. Now, the main thing is that if you are going to measure the blood pressure of a neonate, okay, there is usually a bladder in the blood pressure machine, like the blood pressure cuff. There is something in it, that thing which gets big. You know, it's not everything that you use to tie the child's hand that usually gets big. There's a bladder in it, and that bladder should be about 44% to 55% of the arm circumference. That's all that it is saying.
Right.
0.44 is the same. Yeah, okay, good. Now, objective 1B says list and interpret critical clinical findings, including signs of secondary hypertension. For example, coarctation of the aorta and renal disease. So, iPhone, remember, you were asking the question. I told you to hold it because we'll come there. Now, it is time for us to get into all these details. All right?